So in today's class, we'll discuss about the bloodstream infections. Okay. Now, bloodstream infections, as the word itself means, it is the infection in the bloodstream. Normally, I think you have the understanding that the blood as a whole is a sterile area. Now, sometimes the blood may be infected. Now, the bloodstream infections means organisms are present in the blood which is not supposed to be there. Hence, it will have consequences, some serious consequences, and many a times you can find the patient ultimately moving into what is known as disseminated intravascular coagulation or DIC, shock, and even death. Now, typically, earlier when the understanding of the microorganisms infecting human bodies were very much limited in the history of the medical sciences, the predominant cause at that point of time was bacteria. Hence, various terminologies was used. Some have become redundant as of today. Today we'll go through the terminologies first. Now, if bacteria is the microorganism that is present in the blood, we call it as bacteremia. Similarly, if the infective organism is a virus, we call it as viremia. If it is a fungus, we call fungemia. If it is a parasite, similarly parasitemia. Another important part is what is known as toxemia. Toxemia means presence of toxins in the blood. Now, these toxins could be toxins which have introduced into the body from outside, or because of the microorganism producing toxins, either endotoxin or endotoxin, which ultimately spread from a local site to the bloodstream or within the bloodstream itself. So, this is called as toxemia. Another word you would have read is called as septicemia. Well, septicemia means presence of microorganisms which are multiplying in the bloodstream and or producing toxins. As of today, the word septicemia is not used more prevalently, because earlier, as I have already said, the predominant causative organism was looked as bacteria. But today we know many other organisms like viruses can cause the similar symptoms. Hence, septicemia term as of today is not used very commonly. The next is, now bacteremia means that is bacteria present in the blood. We can classify bacteremia based on various methods. First method is whether this bacteria is present at all times, sometimes, or transiently. Based on that, we can call it as either transient bacteremia. Now, what is transient bacteremia means? Sometimes very few bacteria may gain access into the body because of normal routine work, which may include even simple activities like brushing your teeth or chewing of food. However, in an immunocompetent person, transiently these bacteria, when it gets enters into bloodstream, are rapidly cleared and is of ultimately of no consequence. However, we must be aware in other patients, that is, patients who have immune suppression or undergoing any surgical or operative procedure. In that scenario, even transient bacteremia ultimately may lead to sepsis. Okay. Next is continuous bacteremia. Continuous bacteremia is a phenomenon in which the source of the infection is within the bloodstream itself. And because the source is within the bloodstream, there is a continuous flow of bacteria or pathogens from that source into the bloodstream. For example, it could be because of intravascular infections in the catheters, or it could be due to endocarditis. The next is intermittent bacteremia. Intermittent bacteremia is classically seen when the infective focus is outside the bloodstream. For example, an abscess. The bacteria spills out from the abscess intermittently into the bloodstream. The same phenomenon can also be seen in infections like meningitis, pneumonia, and osteomyelitis, especially in the early phases. As the infection goes on or proceeds further without any treatment, it ultimately becomes continuous bacteremia. Similarly, we can also classify bacteremia as primary bacteremia or secondary bacteremia. Primary bacteremia means all the infections which predominantly affect the bloodstream or the reticuloendothelial systems, including enteric fever, brucellosis, leptospirosis, etc. Whereas secondary bacterial infections are when the infective focus is outside the cardiovascular system. Now, regarding cardiovascular system, we can again divide whether the infective focus is intravascular or extravascular. When we are talking about extravascular infections, we must look for specific organ systems because they act as the portal of entry of organisms into the bloodstream. For example, urinary tract, intestine, meninges, reticuloendothelial system, lungs, or even surgical site infections. Now, this is very important because for particular systems, some particular microorganisms infect more commonly than others. So, in a patient with sepsis or unidentified bloodstream infection, the portal of entry is very important. It can give a diagnostic clue of the possible pathogen. Now, factors which do contribute to bloodstream infections, first is immune suppression. That means an immunocompetent patient is more likely to get rid of the pathogen from the bloodstream as compared to the immune suppressed patients. Use of broad spectrum antimicrobial agents, invasive procedure, any type of invasive procedures including surgeries, instrumentation, catheterization, extensive surgeries, and prolonged debilitated patients. Well, in these two cases, what happens is there is a translocation of microorganisms, especially in the intestinal, that is the gastrointestinal tract and the genitourinary tract. That means the microorganisms penetrate through the mucosal barrier and into the bloodstream. Now, let us look at the two important causes. First is infective endocarditis. Now, what is infective endocarditis? It is known as the microbial infection of the endocardial surface. Okay. Now, the cardiac region, I think you have read in anatomy, there is the endocardium, there is myocardium, and there is the pericardium. So, the endocardium is where the blood comes in contact, and from there the endocardium is infected, and the more predominantly the valves of the heart become infected. It could be native or it could be prosthetic. Now, a very important feature is vegetations. What is vegetation? Vegetation is basically a collection of the microorganisms along with cellular debris. What cellular debris? It could be platelets, fibrils, and inflammatory cells. Why it is called as vegetation? Because in diagnostic methods it looks like a growth, hence it is called as vegetations. Now, these vegetations can be found at various locations, commonly the heart valve, the chorda tendineae, endocardium, endothelium, and even in the septal cardiac abnormalities like a VSD or a ASD. Now, endocarditis have some risk factors. What are these risk factors? Risk factors include rheumatic heart disease, now degenerative or mitral valve disease, intravenous drug abuse, poor dental hygiene, diabetes mellitus which is poorly controlled, then hemodialysis, mitral valve prolapse, long term catheterization. These are predisposing factors. Clinically, infective endocarditis does manifest as fever, new or more predominant murmurs, splenomegaly, new or changing back pain, splinter hemorrhages, conjunctival or retinal hemorrhages, cough or new onset pleuritic chest pain, and even stroke syndrome. Stroke syndrome, why? Because the vegetation may get dislodged from the endocardium and get lodged into the cerebral circulation, causing what is known as stroke. Now, when we look at the organisms, basically it has been divided into two parts, either culture positive or culture negative. Now, culture positive means when we are trying to obtain the culture from by culturing the blood of the patient conventionally, some organism grows, some don't. Based on that, we can divide whether the endocarditis is a culture positive endocarditis or culture negative endocarditis. Okay, it is just based on laboratory identification. Now, culture positive organisms, if you see the commonly Streptococcus, Staphylococcus, Enterococcus, and in gram negative we can see E. coli, Pseudomonas, Corynebacterium bacillus, and Strep pneumoniae and Strep pyogenes. Now, these organisms are easily cultured in the laboratory. Now, if we look at the culture negative organisms, remember these organisms can be cultured. In the lab, they can be cultured, but commonly from the clinical investigation, culture comes as negative. These include nutritionally variant streptococci like abatrophia and graniculata, Bartonella group, Coxiella, Hassett group is very important, that is Haemophilus, aggregative bacterium, Cardiobacterium, Echinella and Kingella, Chlamydia, Porphyria, Legionella, etc. Now, next are the investigations. How to diagnose? The first and most important part I have already said is the blood culture. How many blood cultures we should take? We should take at least 3 sets of blood culture and it should be taken from 3 different anatomical sites. Okay, the more the merrier, because even though it's the infection of the endocardium, the bacteremia is not continuous. Okay, because of the intermittent bacteremia, the chances are the more blood samples you take for the culture, the probability of diagnosis becomes higher. It should be at least 3 sets. Other than that, we can do investigations, other investigations like the complete blood count, the brain natriuretic peptides, serum antibodies, especially to find out organisms which do not grow in culture. For that, we can do serological investigations, ECG, echocardiography for monitoring of the vegetations, urinalysis, and even CT scan. Now, diagnosis is based on what is known as the modified Duke's criteria. Now, this Duke's criteria has major criteria and minor criteria, and the diagnostic criteria includes that either we can diagnose it as a definitive endocarditis or a possible endocarditis based on the number of the criteria which are fulfilled. That is all about infective endocarditis. Next, we move on to what is known as catheter-related bloodstream infection. Now, before going into the bloodstream infections due to catheter, you should have some understanding of what a catheter is. Basically, catheter gives the access into the bloodstream. Okay, external access. Now, why this access is needed? This access is predominantly needed for giving medications including fluid and drugs. Sometimes it is also used for monitoring of the various parameters, like a central line can be used to monitor the mean arterial blood pressure. Okay, and even like renal continuous renal replacement therapy. Now, the various types of catheter that you should know is first catheter is called as the peripheral line catheter. If you visit into the ward, you will find many patients are given intravenous fluids by a peripheral catheter. Now, what are peripheral catheters? Peripheral catheters are catheters which gains access into the peripheral vein but do not gain access into the vena cava. That is the superior vena cava. Understood? Now, why this is important? Because it gains access into the peripheral line. The chances of infection moving from the peripheral vein into the central bloodstream is very less. Next type of catheter would be a midline catheter. Now, this catheter you will very commonly seen in our hospital. Now, this gains access into the large veins. Okay. Hence, the chances of infection are even higher. Another comes is a peripherally inserted central line catheter. Okay. Now, try to understand the difference. The midline catheter is placed very close to the neck. Hence, the chances of infection is higher because of the proximity to the central vena cava at the site of insertion. It was funnily designed to make it as distant as possible, but the access gains into the vena cava. Okay. So, it does the job of the midline catheter, but the insertion point is more peripheral. Hence, the chances of infection are higher. So this type of catheter is more commonly used, in which we assume the patient is going to need treatment for a more prolonged time. Finally, what we is a surgically implanted catheter. These catheters are placed surgically with a production of a tunnel, and there is a probe by which is under the skin, through which we can use medication. This is used especially in case of patients who need long term therapy. For them, we need a long term access. Now, because it's a surgically inserted, hence the probability of this catheter getting infected is even higher. Now, having understood the types of catheter, you have understood at least one thing. The type of the catheter depends on how long those to be used. Based on that, we can divide whether it's a long-term catheter or short-term catheter, as the name suggests itself. Now, the long-term catheter, like the surgically implanted catheters, why they are used? They are used for who require prolonged chemotherapy, hormone infusion, or hemodialysis. Okay. Whereas the short-term catheters are commonly used in the intensive care units, where we assume that the patient will be needing the medication for about 1 week, and after which we can remove the catheters. Now, why this is important? Because as the more you keep the catheter in the body, remember, a catheter is a foreign body. Whenever a foreign body gains access into the body, the chances of this becoming a nidus for infection becomes higher. Hence, long-term catheters will be infected, as the chances are more higher as compared to the short-term catheters. Now, before delving into the infections, you should be acquainted with some of the terminologies. First is colonization. Now, what is colonization? Colonization basically means the situation in which the catheters get colonized with microorganisms. That means the organisms gains access into the catheter. However, it does not spread from the catheter into the bloodstream. That means it is just present over there. Now, when colonization occurs, the chances of infection becomes very high. Any kind of manipulation may lead to dislodging of the microorganisms from the point of colonization into the bloodstream. Next, you should know what is phlebitis. Phlebitis means infection and inflammation of veins. This is commonly seen with peripheral catheters. As you can see, this is the site of insertion of the catheter, and there is a redness and swelling toward the limb. Now, peripherally inserted catheters may result in phlebitis. However, this infection is restricted to locally and does not spread into the bloodstream. Another type of infection that can be seen is known as exit site infection. What is exit site infection? At the point of insertion into the skin, that area might be infected. If it is localized up to 2 centimeters from the point of insertion, we call it as exit site infection. If it is beyond that, then we call it tunnel site infection. What it means? If the infection is restricted to the point of insertion, we call it as exit site infection. If the inflammation spreads beyond 2 centimeters, that means the passage, the tunnel that is created by the catheter has been infected. And finally, another route of infection is infused related infection. That means whatever medication or fluid that you are giving through these catheters, infection can be acquired from those. The fluids might be contaminated, hence causing the infection. Now, catheter-related bloodstream infection, we define them as bloodstream infections which occur, that is 48 hours having the catheter. Why? Because for the process of colonization to dislodgement or dissemination of the colonized pathogen from catheter into the bloodstream takes at least 48 hours. If the onset of infection is within 48 hours, that is less than 48 hours of insertion of the catheter, probably this is not a catheter related infection. Okay. Then the infection might be a local infection, it could be a phlebitis, it could be an exit site infection, or it could disseminate through the body. That is when we call it as catheter related bloodstream infection. Now, what would be the routes of infection? The first route would be migration from the skin flora. Remember, the patients, their own body have some microorganisms. During the time of the insertion, you may provide access to these organisms into the catheters. Okay. Hence, so what could be the routes of infection? First is migration from the skin flora. Now, this commonly happens during the insertion. If there, remember, placement of a central line catheter is a sterile procedure. All aseptic process must be followed, including cleaning and disinfection of the asepsis of the site of insertion. If any of these process, there is a breakage in the septic process, chances are the catheter would be infected. Okay, by organisms from the skin flora. Okay, remember, this is very important of the insertion burden. Next comes direct contamination of the catheter hub by the healthcare workers or anybody who is handling the central line. What are the hubs? These are the hubs through which medications or fluids are given. If the healthcare worker does hand hygiene, there is a break in infection control processes, the hub may be contaminated, and from there on the infection might go. So this is important in case of maintenance bundle. Okay. Similarly, there could be a hematogenous spread. Now, hematogenous spread means the person may be admitted because of any other disease or ailment. Okay. Not always the patient is infective. Okay. And then develops an infection at a distant site, say an abscess or an UTI, etc. From there on, the bacteria goes into the bloodstream, and from bloodstream, the bacteria may also gain access into the catheters. But this is not a catheter related infection, but you may find culture coming out as positive. Okay. And finally, rarely, it is the medications or fluid that you are giving that might be contaminated. Okay. This possibility has also, you have to keep in mind. Now, then let us look at what are the organisms which can cause. First, you can see the gram-positive organisms. These organisms are commonly present in the skin, which include coagulase-negative staphylococci, Staphylococcus aureus, which may be MRSA or MSSA, and Streptococcus species. Especially in the hospital environment, some of the organisms are very common. Those include Klebsiella, Enterobacter, Pseudomonas, Proteus. So they are very commonly causing hospital acquired infections. Now these organisms gain access in the hospital environment. And even some fungal agents like Candida and Malassezia. Both these fungus are present in the skin. Next, if a patient is suspected of having bloodstream infection, what are the investigations that you should do? It includes complete blood count, metabolic panel. Now, catheter tip culture. If you see signs of exit site infection, where there is erythema, there is oozing of serous fluid, or sometimes even visible pus, you can take a swab and put that for culture. Other investigation would include radiological like ultrasound, CT or echocardiography, but very important is blood culture, because that is the definitive way of diagnosis. Now, how we will decide whether this is a case of CRBSI or not? We have to take at least 2 sets of blood culture, one from the catheter line, one from the peripheral line. Okay. Now, try to understand this concept. If the focus of infection is within the catheter, what will happen? The bacterial load in the blood sample taken through the catheter will be much higher as compared to the bacterial load in the circulation. Have you understood this? Now, if it is not a case of catheter related infection, the amount of organisms in both the samples will be more or less equal. Have you understood this or not? If the source is catheter, we take a peripheral blood sample and a blood sample from the catheter, what will happen? The sample from the catheter will have a higher load of bacteria as compared to the peripheral line. And if it is not a catheter related infection, what will happen? Both the blood sample will be have more or less equal amount of bacteria. That means the source is elsewhere. Say there is a gluteal abscess. So the organism is translocating from the abscess into the bloodstream. So both the blood sample will have more or less equal blood sample. Now when we put the two bottles into a culture, the one with a higher quantity will come culture positive more quickly than with the one with the lower quantity. The higher is the initial load, the higher the rapid, more faster the blood culture will come positive with the higher quantity count. Okay. Now conventional blood cultures we do not get the time, but we can estimate the quantity. Whereas automated blood culture system, we can get the timing of when the blood culture comes positive. Based on that, we can define is that first is both the bottles should have same organisms. If not, there is error in the diagnosis. Okay. Next, the peripheral blood culture and the catheter lumen culture, the culture growth is detected 2 hours earlier in the catheter lumen because the load is higher, or the quantity is threefold greater. Then only we can say it's a catheter related infection. Okay. By conventional culture, we can get the total quantity. By automated blood culture system, we can get the time by which the culture comes positive. So remember, if the culture comes positive in a 2-hour time frame, that means it's a high possibility that this is a catheter related infection. Now, what management we have to give? Please remember the maintenance bundle, the insertion maintenance bundle. Then we have to ask ourselves whether the patient is really in need of the catheter, and if the patient is in need of a central line catheter, how long we have to keep the catheter. The prolonged the catheter is placed in situ, the chances of infection are higher. And finally, we have to maintain a high degree of suspicion. Whenever we place the catheter, if the patient is showing signs of any infection, we have to keep in mind that this catheter might get infected. Now, next, a very important concept is what is known as sepsis. Now, what is sepsis? Sepsis is a state in which the patient is having inflammation in the body. Okay. Now, this concept is not new. This concept can be found in the medical literature since prehistoric times. Prehistorically, people used to think that microorganism will either lead to fermentation or putrefaction. And they used to think that putrefaction is deleterious to the human body, whereas fermentation is beneficial. Hence, it was called as pepsis and sepsis. Pepsis means that which is beneficial to the body, and sepsis means that which is harmful to the body. Furthermore, in the medical literature, we can find the Homer in his literature mentioned the word sepsis, then Hippocrates, then Galen. They all tried to explain what sepsis is. The Roman culture we can find mentioning sepsis and the importance of hygiene in prevention of sepsis. Although they did not give exact cause or definition, but we can find them. Finally, Dr. Semmelweis, during his practice, stressed on the importance of hand hygiene to prevent puerperal sepsis. Further down the line, the contribution of Robert Koch, Joseph Lister improved the concepts of hygiene in prevention of sepsis. Then, in the recent era, we come to Alexander Fleming with the discovery of antibiotics, and Dr. Edward Frank first providing the guidelines or a methodology of management of sepsis with antibiotics. Thereafter, definitions have been laid down. I will come to it. If we look at this board, I have written previously Sepsis was considered as a process in which the first step was SIRS or systemic inflammatory response syndrome, which prolongs, gets more severe with sepsis, severe sepsis, and septic shock. This classification is redundant now. Nowadays, by the sepsis 3 classification, we have only two terminologies, sepsis and septic shock. I'll come to it later. Now, let us try to understand what sepsis is. Sepsis is whenever there is an infection or inflammation. Please try to understand. Inflammation may be because of an infection or an inflammatory process. It could be infective, it could be non-infective. Okay. Suppose there is an infection which causes inflammation. What this inflammation will do, it will cause pro-inflammatory cytokine production leading to oxidative stress by reactive oxygen species, and it will act on the endothelial cells, smooth muscle cells, erythrocytes, leukocytes, and platelets. This will result in microcirculation dysfunction. Microcirculation means predominantly the capillary circulation, which will result in tissue hypoperfusion. That means in the capillary level, the perfusion will get altered. This will lead to cellular damage by mitochondrial damage, and ultimately in the overall picture will lead to organ dysfunction. Okay. How it does? Because of this damage, the cells will undergo apoptosis on lymphocyte. It will reduce the immune response. Endothelial cells in lung, it will lead to acute lung injury or ARDS. In the kidney, it will cause acute kidney injury. In the intestine, it will lead to mucosal damage. And the intestine, as you know, is filled with many types of bacteria which does not enter into the bloodstream normally because of the mucosal barrier. When the mucosal barrier is disrupted, these organisms translocates into the bloodstream. In the endothelial cells, especially in the capillary and the small vessels, the endothelial cells are damaged, which lead to two phenomena. First is vascular leak and second is thrombosis. How does it occur? Normally, the endothelium has a layer of glycocalyx, but because of the inflammatory response and the cytokines, this glycocalyx layer is disrupted, and because of the cellular damage, these basement cells are damaged. Hence, we can find leaks in the endothelium. Now, this leak in the peripheral may affect all systems, from brain to heart to kidney to lungs, all systems. And regarding thrombosis, this will lead to what? Triggering of the coagulatory cascade, and it will use up fibrin and thrombin products. And when they are used and the capillary leakage occurs, we call it as disseminated intravascular coagulation. That means coagulatory proteins are used up within the vessels itself. Hence, when there is a leakage, the coagulation pathway cannot act anymore. Effectively, the patient will bleed out. Now, having understood this, there is two. Sepsis is a stage when in one side the inflammatory process triggers various activities, whereas the immune system tries to suppress the inflammatory process by immune suppression. It is basically a seesaw. Okay. When the inflammatory process increases, the patient's condition deteriorates. When the immune suppression of the immune system of the body takes up, the balance tilts on the patient's own side. Now, this is the reason why the new classification says it's a sepsis. Could be infective, could be non-infective. The basic fundamental thing is that it's a battle between the inflammatory and the immunity of the body. Now, previously, as I've already said, the first classification was given as SIRS, that is Systemic Inflammatory Response Syndrome, and it was categorized. Okay, you can find this in many of the textbooks, but it is not required now. It has become redundant. Now, what is more important is you should know what sepsis is. So, in a layman term, sepsis is a life-threatening condition that arises when the body reacts to any infection or inflammation. Specifically, sepsis is characterized by life-threatening organ dysfunction due to dysregulated host response to an infection. It is basically an organ dysfunction. So, if multiple organs become dysfunction, we call it as MODS or multiple organ dysfunction syndrome. Okay. By sepsis 3 categorization, sepsis shock has also been defined. I have already said sepsis and sepsis shock. That is, septic shock is a subset of sepsis where particularly profound circulatory, cellular, and metabolic abnormalities substantially increase mortality. What does it mean? It means that in the process of sepsis, there might come certain stage in which there is metabolic abnormalities and circulatory failure. Then we call it as septic shock. Now, how to identify sepsis? Well, two most common way of identifying are the SOFA and the Q-SOFA score. The Q-SOFA or the quick SOFA score can be utilized in patients who are not undergoing intensive care. For that, the categorization is altered mentation, higher respiratory rate of breathing, and low blood pressure. So, any patient in the ward in which you don't have various parameters that you can go through, you can quickly assess the patient whether the patient is actually under sepsis or not. Okay. So, the patient will have low blood pressure, increased respiratory rate, and altered mentation. If this happens to any patient, you have to suspect sepsis in that patient. However, if the patient is admitted in intensive care, we can get various parameters depending on whether the patient is under mechanical ventilation or not, etc., etc. So, if we assess all these parameters and a score of 2 or more comes, we can categorize the patient is having sepsis. Okay. For septic shock, try to recall the definition. It was metabolic abnormality and circulatory failure. How to assess that? First is, in spite of use of vasopressors, the mean arterial blood pressure cannot be maintained. Okay. When we give the vasopressor, when the patient cannot maintain the mean arterial blood pressure, we need to give vasopressor. We are giving the vasopressor, yet the patient cannot maintain the mean arterial blood pressure. That means there is a circulatory failure. Furthermore, if there is elevated serum lactate, why serum lactate? In the cellular level, if the perfusion is not enough, the cells will undergo, what will happen? Exactly, that will raise the lactates. So, if the patient in intensive care, the lactate levels are going up, that means there is peripheral tissue hypo or no perfusion. So, these are the two conditions. If met, we classify that the patient is undergoing septic shock. Have you understood? Now, let us look at what are the causes of sepsis. Remember, it could be infective, it could be non-infective. Let us look at the infective process. The common organisms in gram-positive, Staphylococcus, Streptococcus, Listeria. In anaerobic, we can find Clostridium, including Clostridium difficile, which causes Clostridium difficile associated diarrhea. Viruses like cytomegalovirus, herpes varicella, fungi like Candida. Coming to non-infectious causes of sepsis, this would include trauma, burn, surgery, AMI, severe pancreatitis, adrenal insufficiency, acute leukemia, or malignant hypothermia. These all can cause sepsis. Okay. Now, if a patient is having sepsis and if you suspect the patient the cause could be infectious, you have to look for sites of infections. So what would be the sites of infection? It could be bacteremia, it could be infection because of any kind sort of catheter, whether it's a central line catheter or a urinary catheter, or it could be intra-abdominal infections like pancreatitis or pelvic inflammatory disease. The focus could be the lungs. So we have to look for signs of infections by fevers, irritability, confusion, tachypnea, raised respiratory rate or respiratory failure, hepatic or renal failure. These are indications of infection. However, you must go through the proper history. Now, this is especially important in case of sepsis because we need to look for clues. It could be based on a clinical examination or the history. Now, some points in the history are important. First is age. Why age is important? Obviously, extremes of age, whether in the neonatal or the infancy or elderly, they are more prone to infections because of immune suppression. Similarly, we need to know the history of present illness, whether the patient did had any antecedent infective process going on, or say a trauma or a elective surgery that was done recently. Then we need to get to know about a past medical history, whether the patient was being treated for any sort of disease or not, whether he, for example, infective patient may be treated for infective endocarditis, or the patient may have a say a septal defects, etc. Then we need to know about the medications and allergy. Now we have given many criteria like a raised blood pressure, etc., etc. Some patients is like patients with hypertension, they are treated with antihypertensive medication which will reduce the blood pressure. So when you actually measure the blood pressure in this patient, you might get an erratic results. So you must assess whether the patient is under any sort of medication or not. The patient might be allergic to say any drugs or say very commonly peanuts, etc. It could be an allergic manifestation also. Then we need to know the social history. The patient might have a history of injection drug abuse that will lead to other probabilities. Furthermore, in physical examination, very important is that you should assess vitals. Many a times it is neglected, especially on the doctor's part, the vitals. But they are extremely important. Why? Because the vitals give you the first sign or clue of sepsis. Okay. So in any patient, please do not disregard the importance of vitals. Few clues can be found out in the physical examination, like when a surgical site, surgical infection, in case of injection drug abuse, puncture wounds on the arm might give an indication. Sometimes the causative organism may also give an indication in the derm, like pseudomonas might be associated with ecthyma gangrenosum. Okay. Similarly, examination of the head, ear, nose, throat can also give many clues. Cardiac examination is similarly important. Look for new murmur or extension of the existing murmur, echocardiography. Pulmonary examination, there could be a consolidation or there could be an effusion which has been overlooked. Then neurological examination might give the early signs of meningism, sorry. Similarly, musculoskeletal examination and abdominal and pelvic examination. This is very important, especially in case of females. Pelvic examination is very important because pelvic inflammatory disease may result in all. Now, how to approach it? All the necessary investigation would include a complete blood count, metabolic panel, PT, APTT, INR, serum lactate is very important, and then look for the infective focus like urine microscopy and culture, blood culture, and other investigation like a radiological investigation like a chest x-ray or CT scan if we are looking for a pulmonary focus, We can also go for a abdominal CT scan or abdominal ultrasound if we are looking at a abdominal pelvic infection. Now coming to the management of sepsis, most important is fluid resuscitation, vasopressure or the inotropic support. Why? Whatever may be the cause, the sepsis shock result in tissue hypoperfusion. So we have to correct that. That is why the most important management is fluid resuscitation and vasopressor support. Thereafter, we need to give corticosteroid therapy. Why? Steroid reduces inflammation. Okay. The whole pathogenesis starts with excessive inflammation. Next, we might need to give blood product administration. Why? Because when there is a capillary leakage, along with the blood, RBCs also leaks out. Now, what is the role of RBCs? Is to provide oxygen at the tissue level. Anemia in this setting can be very deleterious. So, blood and blood products may be given. If the coagulation cascade is triggered, we need to give plasma as a replacement therapy to control the DIC. Similarly, glucose control. Why? Many a times you will find the patient will have, although maybe diabetic, maybe non-diabetic, but in this scenario the patient may have raised blood glucose level. Now high blood glucose in this setting will lead to, if it is an infective cause, the organisms will multiply even further. Hence, glucose control is also important in this setting. Renal replacement therapy, because the kidneys get injured, the patient may go into AKI and the products may be retained within the blood, which may trigger this process even further, for which we need renal replacement therapy. So this picture shows the summary of all the therapy that can be given. It is just for a representation, it is not exhaustive. This would include like vasopressor therapy, antibiotics, fluids, insulin therapy. The patient may have to be kept under sedation depending on the situation. Patient may have to be given ventilatory support with a ventilator. These are some of the examples. Finally, the most important part of sepsis is that we have to suspect sepsis as early as possible, because once the patient goes into the sepsis and septic shock, the chances are we may lose the patient. So to prevent this, we have to suspect as early as possible.